See a case of we'll see a case of stent failure, and we can discuss how imaging can help. This is about a 54-year-old man that had an anterior STEMI and primary PCI on the 24th of September. And please keep in mind the details because they are important. He had PCI to the LAD with a 275 times 38 stent. And then, because there was stenosis at the diagonal, the operators placed a 2 mm by 20 stent in the diagonal. Based on the report and the images that we reviewed later, there was no further modification for this bifurcation PCI. The patient was on aspirin and ticagrelor, but what happened? Just a few days later, while being in the hospital, he developed chest pain and lateral ST elevation. There was no PCI availability at the time in the hospital that he was in, so he was transferred to our hospital for primary PCI. Okay, we had to use the femoral, that's not important, but have a look on the image here and we see what we expect. The diagonal stent has been thrombosed. We are talking about an acute thrombosis. Just to remind you, he had this bifurcation PCI 4 days earlier. We crossed with a wire and we see some restoration of flow. We wanted to achieve better restoration of flow, so we did dilatation with a small balloon, and this led to better flow and resolution of the symptoms and the ST changes. But when I try to do what we're usually doing in stent failure, doing an imaging, you can see that there is no possibility for the OCT to cross, although I'm pushing a lot, you can see how the guide catheter is moving. In order to help maybe the discussion, I will show you also these two images, and this is a stent boost, and what you can see is that the stent in the diagonal is protruding within the LAD. I think it's very obvious in both pictures. I will stop here and maybe we can discuss how we can proceed starting from here.
Did you have a possibility to see the previous angiogram and what technique was followed by the operator?
Yeah, so the technique is as I described. They placed the stent in the LAD, and then there was a stenosis in the diagonal, and they put a stent in the diagonal. I don't know if they are trying to do something like a tap
technique. Maybe.
Yeah, tap kind, although the angle is very narrow to allow this. And there was no further kissing or pot.
You can see, I think, on the imaging that some of the diagonal stent is protruding into the... Yes. I mean, this is... I don't know if you can see that on your screen, but it's clearly. So obviously, it was not a very ostial position of the stent.
It wasn't ostial at all. I think in any case, in this kind of angle, you cannot achieve an ostial position. Either you miss the ostium or you go inside the main branch.
That's a very important comment, I think. That's a very important comment because the angle is such that either you miss the ostium or there will be a long metallic neocorena. The problem is, what do you do with the long metallic neocorena? So, I mean, if you do the kissing, then it will remain. So the only thing that you can do to shorten the metallic neocorena, if it's very long in such situation, is crush it. But for that, you, of course, need imaging to see where you are with your wires. Crush it, then rewire, and that's the way to shorten it, if possible, because there could be a lot of tissue there as well, which can make a problem.
And as you saw, I couldn't deliver the OCT. Someone could say, okay, maybe try to recross, but don't forget it was a STEMI case. So what I decided to do was exactly this, to crush the diagonal. In any case, that would be my strategy at any point. So I crushed the diagonal stent with a 3.5 inch balloon.
Can I make a comment?
Of course.
I mean, crushing is the only basically thing that you can do now. But remember, you're going to have two metal on the same side, right? So it's going to be quite difficult. You're not doing. They haven't done double kissing or anything like this. So it's going to be two metals stent frames in front of the. So it would be very tough. So that's what I'm saying. You know, to get
of course, of course.
You have to verify that your wire for the LAD is not going through the struts of the diagonal.
It could be, but my decision at the time was that this bifurcation stenting is lost, so I would do something more. So I crushed it, and then we did this OCT that I think Professor Guagliumi is going to comment now on it.
So practically speaking, it was trying to get the OCT catheter down, but it was mentioned before, there was some clear protrusion, and then perhaps there was also some distortion. At the end, it was crashing by using the balloon, so the actionable based upon angio, and then he did this OCT. Just for understanding, first of all, the central part, that is not obvious. So what is the difference? The difference is at the end of the pullback, with these images, you have everything. You have the longitudinal view. We are not watching only to the cross-sectional view, but here is the distal, here is the proximal, here you have the reconstruction of the stent, and eventually you might have also some additional information. I'm moving. This is a piece of the stent distally. We are at this point where we can have a nice full apposition of the struts. Let's go this way. Here you can see that, start to see that you have some malapposition. So the first point is when you are assessing imaging, have a clear look in terms of measurements and in terms of apposition of the stent. Then we are going back. And then we are approaching this segment where you are plenty of the red spot. Okay, this is after the crashing. And here is the stent that was pushed toward the diagonal. This is the origin of the diagonal branch. And then I'm moving of a few frames. Here you can see again. And then I'm moving back. And then I'm moving back again. And that is very funny. You can start to see that from one side, 3/4 of the vessel, you don't have any struts. While on the opposite side, you have this dual struts level. One is here, and the other one is this way, optical. If I'm going here, and I'm asking to trace the lumen contour, this is the lumen contour, but in fact, this is the contour of the vessel. The contour of the stent was significantly distorted, also at the entrance. And that could be another reason why it was not able to get the OCT imaging down. So they are basically the information that you can collect, and then we are going back to this point. Let me say, it's very challenging from this side. And here you can see again the distortion that was very prolonged and going this level, and then this is the normal proximal site of the vessel. That was basically what it was. Dejan.
That was great. I mean, that was great because you just basically could see that there is this oval shape of the stent which is pushed from one side of the vessel wall to the other, which I think is the result of the first wire being a few millimeters at the beginning abluminal. And this is what I think is an important message. So if we have a stent failure event, then you need to think about already in front that this is most likely a result, or could be a result of the mechanical problem. So the first wire down the vessel could probably, small balloon, and then probably follow it with imaging. Why small balloon? Because if you are abluminal, the small balloon would not have made this kind of a distortion. Distortion will be smaller, so you have then better chances of going in. Once you establish flow, it's a STEMI, of course. Once you establish flow with a small balloon, I would try to do imaging. And if it doesn't work, I would try to put another wire. So I would always keep, in a STEMI case, the first wire in because you need the flow. But I would get another wire in and then try the imaging with that wire in to see whether in which lumen I am. Because 2 or 3 millimeters at the beginning of the stent can make this kind of a problem.
So we can go back to maybe to the presentation, and now we have this situation. This proximal LAD stent is actually destroyed. And okay, we saw that. You can see, I just let it play to see how easily now the OCT goes down because we have the distortion that we saw earlier. And the decision was to proceed with another stent. To be honest, this was my thought from the start. I thought that this proximal LAD stent will be lost anyway. It was too small for this proximal LAD. It was a platform of 275, just to remind you. And so I did a further predilatation, and I placed a 3.5 stent, just trying to cover that area. Post-dilating with 4. And then we did another OCT run. I don't know, maybe for the, I don't know, Julie, if we can skip this, or do you want to show this too?
Going to the last one?
We can go to the last one, maybe just to save some time. In that previous run, there was under expansion in the old stent, in the middle AD. So I did also some post-dilatation there with a 3 mm balloon. I rewired the diagonal. And then I proceeded also with post-dilatation in the diagonal. The stent was 2. I did with a 2.5 balloon. And then we did kissing with 4 and 2.5 balloons. And then we did runs both in the LAD and in the diagonal with OCT. And maybe we can show the last, we can change back to the laptop and see the last run in the LAD.
Okay, I think this is the last run in the LAD. Let's try to get much more clearly depict the diagonal. Here is the bifurcation with the diagonal. This is left main, this is the circ. This is the proximal half of the LAD going from the entrance. When you have some red dot, sometimes is the blood that is going to be misinterpreted by the AI. So almost all the strata are pretty close to the vessel, and so there is no big malposition. Here you can see some artifact. It seems that you have a struts inside the vessel. This is the blood. So that is another reason to try to be very precise in terms of cleaning of the lumen. Here you can see double layer of the struts. You can count how many white spots you have at this point. And here we are going to the bifurcation. You can see that the carina seems to be more or less neutral at this point. Here you have the origin of the diagonal branch. And then going in terms of expansion, when you are seeing this question mark, you click and you are accepting. And here you might have some better idea about the expansion. You move in the proximal and distal reference according to what you have, and you have a frame by frame the expansion rate. And this is what you can get from the automatic lumen detection.
If we can go back to the presentation. Based on this run and considering the measurements not of the lumen but the measurements of the external elastic lamina, I thought that we could do something even better for the expansion and the apposition of this stent. I remind you once again that the stent placed in this proximal LAD was the old stent, the previous stent was 275. So we did another post-dilatation. I described this as final pot with a 4.5 millimeter balloon. And this is the final result.
Any comment?
Congratulations.
Congrats, Grigoris. I think that the game changer was that you tried to use the OCT from the beginning, so you understand from the beginning that the stent was distorted. But if it wasn't available, do you think that from the enhancement tools like stent boost, I think that it was pretty obvious that
this is a good point, Erasmus, and Professor Vavuranakis also mentioned it, that from the very first angio shots, when we did the stent boost, you could see that the diagonal stent was protruding within the LAD. So in a way, we had in mind what is the problem that we're going to face. Plus the small stent for the proximal LAD. Obviously, it changed completely with the use of imaging because you can see how different sizes we used, and I think you can see also the result.
Let me ask you some question to the panel. If you don't have the OCT, we do have it today, but you think IVUS could help you the same way?
It is more bulky than the OCT, and you will understand earlier that it is distorted. I don't know if it is so easy to cross this.
I mean, you'll have experience with the
yes.
IVUS, right? So
yes.
So I think that all the images can tell you better the situation inside the vessel compared to the angio. And so I think that despite you have a little bit of more challenging in identification, you can clearly recognize a largely distorted struts, and perhaps is a little bit more challenging to see the abdominal wire. But if you are following the instruction about the longitudinal view, you can clearly see where the wire is going. The same picture shown by Dejan in his case was showing this wire going in and then out and then in again. So this is possible with all the images and technique.
I think the reason I made this comment is I think it's very helpful that you have the longitudinal image. That helps you understand what's going on within the vessel. IVUS also you have longitudinal, but I don't think it's so clear in this case where you have this complicated malapposition, stent distortion. So I think it was very, very helpful that you have your OCT in this case.
Good.
Congrats. Fantastic demonstration of what the imaging can show us. But I think as well in this